Cerebral palsy can be described as a group of neurological disorders that affect movement, coordination, and posture due to damage to the developing brain. There are many symptoms that come with cerebral palsy, and it all varies depending on the severity. Some of the symptoms include delays in reaching physical developmental milestones, such as sitting or walking. Body is either too stiff or flaccid. There are a lot of weakness in their arms or legs. The child may experience fidgety, jerky, or clumsy movements, very random, uncontrollable movements, muscle spasms, or walking on their toes. Imagine a world where children with cerebral palsy are empowered to move, explore, and interact with their environment just like their peers, where using your arms and shoulders to lift a backpack or to play a board game is not a complicated task. A world where robotic assistive therapy using technologies such as Gloria gloves and R.A.T plan robots new possibilities for school readiness and But what are these robotic supportive devices, and how can occupational therapists utilize them to make a positive impact on the lives of children with cerebral palsy? While many studies show that robotic assistive therapy improvements in lower extremity mobility is successful, today we are going to focus on various types of robotic assistive therapy and its effects on improving upper extremity functional mobility to prepare for school and handwriting. Today, we are going to explore our 3 objectives. 1, how can occupational therapists use robotic assistive therapy with various children with cerebral palsy? 2,
the first study involves the Gloria Symphonia exoskeleton, which aims to evaluate the effectiveness of using R.A.T training in children diagnosed with cerebral palsy. The participants included 7 children between the ages of 6 to 18 years old with a moderate to severe impairment of the upper extremity or a max score greater than 1, and must have the ability to understand 2-step instructions. Exclusion criteria for this study were presence of other diseases that can affect movement, received upper limb therapeutic interventions within the past 6 months, either Botox or surgery, and if the children had visual or auditory impairments. All children were seen twice a week for 60 minutes over the course of 8 weeks utilizing the glove. A trained occupational therapist conducted the sessions individually for all participants, and each session consisted of a 20-minute warm-up program to prevent spasticity and included weight-bearing and rhythm activities. Then a 10-minute continuous passive range of motion exercises on the fingers. And lastly, 30 minutes of active assist game mode, which was set on the basis of the patient's ability and included bimanual, active assist, and game modes. As for the assessments, all participants were assessed before the initial intervention, after the last session, and 1 month after. Assessments used were the Fugl-Meyer assessments for the upper extremity, electromyography, box and block tests, grip dynamometer tests, and Able Hands Kids. The second robotic study involves the R.A.T plan and aims to assess the effectiveness of robotics therapy combined with conventional therapy in comparison to receiving conventional therapy alone in children with cerebral palsy. 16 school children with cerebral palsy who were younger than 18 years old were recruited. All participants must understand simple instructions and must have a moderate to severe impairment of their upper extremity or a max score greater than 1. The exclusion criteria were epileptics patients, upper limb therapeutic interventions such as Botox or surgery. All children were equally randomized into either a control group or a robotic therapy group. During the 8-week study period, both groups received a total of 40 sessions. The sessions were held 5 times a week for both groups, with each session lasting 45 minutes. In the control group, all participants with the CT group solely received their regular treatment with their physiotherapist. In the robotic therapy group, the participants received 2 robotic therapy sessions and 3 conventional therapy sessions per week. Participants performed exercises with the R.A.T plan. The sessions were in a form of video games. An avatar, which is the cursor that the child had to move, and a cartoon animal, which is the target that the children had to reach, were integrated into an appropriate landscape. Finally, at the end of each exercise, a personalized feedback was posted on the visual interface to congratulate the child and give their time score for achieving the 160 targets. Each of the targets consecutively resulted in audio feedback, deletion of the target, and the appearance of a new target on the screen. This target was randomly placed on the visual screen at a distance of 10 centimeters from the last one. For half of the exercise, the target was motionless as long as the patient did not reach it. For the other half, the target was dynamic, moving a distance of 1 centimeter vertically or horizontally every 0.5 seconds. The amount of movement adapted to each patient and was as high as possible to stimulate improvement, but was also adapted to the child's tiredness. As for the assessments, all participants were assessed before the initial intervention and after the last session based on the 3 domains of the ICF, or the International Classification of Function, Disability, and Health. The assessments included kinematic assessment, box and block test, quality of upper limb extremity skills test, modified Ashworth scale, able hand kids, pediatric evaluation of disability inventory, and life habits.
Robotic-assisted therapy has been studied for its effectiveness in improving upper limb movements and manual dexterity in children with CP. R.A.T utilizes robotic devices such as Reaplan robots to assist patients in performing movements and exercises to enhance motor function. Studies have shown that R.A.T can promote the reestablishment and strengthening of neural pathways, leading to improved upper limb motor control. For children with CP, R.A.T has demonstrated significant improvements in upper extremity function with positive changes in the Fugl-Meyer assessment of upper extremities and increased efficiency in tasks like cube grasping. These findings align with previous research on computer-assisted arm rehabilitation. Combining R.A.T with conventional therapy has been suggested as more efficient than conventional therapy alone. The benefits of R.A.T, such as enhanced motor function and coordination, have been shown to persist even 1 month after the therapy concluded. In summary, the studies demonstrated significant and sustained improvements in upper extremity motor control following robotic-assisted therapy. These improvements included the reconstruction of movement patterns and synchronize of flexors and extensor muscles, resulting in smoother and more accurate movements. The therapy programs consisted of various sessions targeting specific movements and tasks. Robot therapy provided a fun and engaging rehabilitation experience incorporating virtual scenarios and task-oriented training. However, despite the enhancements in upper limb functioning, there were no significant improvements in activities of daily living. These discrepancies could be attributed to participants that have already relied on compensatory techniques favoring the less affected hand. Nonetheless, R.A.T showed promising potential for enhancing upper limb kinematics and manual dexterity. Although these studies provided valuable insight into the effectiveness of robotic-assisted therapy for improving upper limb movements and manual dexterity in children with CP, there are still several areas that required further attention and improvement. Firstly, the absence of a control group limits the ability to determine the specific effects of R.A.T compared to the conventional therapy. Additionally, the study would benefit from incorporating a wider range of assessment tools for ADLs. A larger sample size and longer duration of the training would also enhance the reliability and generalizability of the findings. Furthermore, further research should include long-term follow-up assessments to evaluate the maintenance of the observed improvements. Overall, these considerations highlight opportunities for future research to build upon the current studies and further enhance the efficacy and application of R.A.T in clinical settings. Lastly, research in R.A.T may contribute to new technology advancements, virtual reality integration, and better support children with CP.
R.A.T is an important aspect to support occupational therapists and other healthcare professionals in order to provide positive results that could change the lives of children with their occupational engagement and participation. Based on the two studies discussed earlier, R.A.T has shown to increase upper extremity motor function and engagement in therapy. Although there has not been a lot of evidence tying ADL improvement with R.A.T, these skills still could be incorporated to support ADLs, such as school readiness, with further research and additional assessments. The role of OT focuses on increasing individuals' independence and quality of life. By creating a client-centered treatment plan, this will help cater towards the child's need, such as with school readiness. By R.A.T, it has improved various skills that include upper extremity motor function, brachioradialis muscle recruitment, grasping, hand opening, flexor muscles of the hand, supination, as well as other skills such as coordination, manual dexterity, smoothness, and speed. With these interventions, it focused on a plethora of different assessments. Some of those that overlapped include the Fugel-Meyer for upper extremity movement, the box and block test, as well as the pediatric evaluation of disability inventory. With all of these assessments, it helps support creating a baseline to see progress as well as if the interventions work, which it did, and provided overall an increase of around or above 40%. With the use of R.A.T and traditional approaches, it has helped support increased upper extremity motor function that could facilitate grasp needed for a child preparing for school. The OTs can adjust the settings to allow for a child to participate in engaging activities with things such as the R.A.T plan. They could be playing car racing games as well as playful games that could incorporate just being able to trace over a drawing. By doing this, it will incorporate performance skills needed for school, such as grip, alignment, as well as reaching. Additionally, with these different devices, it allows for visual, auditory, and sensory feedback, which keeps the child engaged throughout the intervention and keeps it fun. With the R.A.T program, it actually showed that it created an average of 744 movements of that repetitive pattern, which could be very influential for therapy. The overall population for R.A.T could be used for anyone with a neurological condition in need of rehabilitation. However, these studies focus solely on the feasibility of R.A.T with children with cerebral palsy, but it is not limited to this and could also include with patients with strokes or those with spasticity. In the profession of OT, we strive to make the impossible possible. Before we conclude our session today, I want you guys to take a second and think about everything that you reached for today, everything that you grasped in your hand. That could be your phone, a steering wheel, or even a pen just to write your name. You probably performed all of these tasks so effortlessly. You probably didn't even think twice about everything that you did. However, how would that be for those who experienced a neurological condition that impaired their ability to do those tasks? What if that individual was your child, someone you love so dearly, and using R.A.T could be that step to let them write their name again on a piece of paper or simply just wave goodbye? Using R.A.T could be that revolutionary step that we need in order to change lives and increase a person's overall quality of life. Through the use of R.A.T and other devices, we could increase that upper extremity motor function to be able to prepare them for school. This could be through grasp, range of motion of that forearm, coordination, and their overall manual dexterity. All of these skills are necessary for a child to prosper and be able to really engage in everyday occupations. Together, let's make the impossible possible through R.A.T. Thank you.